In this talk, we want to talk about the biomechanics of flat foot. And so, first, we want to really define what a flat foot is. And essentially, we can see these three different foot postures where normally you have some amount of angulation or calcaneal pitch, where the calcaneus is pitched backward and the first metatarsal is pitched downward into plantar flexion. And so we can see the navicular height here, this being the navicular bone, is some distance from the floor. So we compare this as our flat foot position here. We can see the navicular now is dropped down to the floor, which means the first metatarsal is dorsiflexed and the calcaneus is plantar flexed. And that gives you this kind of flat foot position now. Essentially, this is an acquired flat foot. So in the acquired flat foot model, we see this plantar flexion of the talus, so the talar head's pointed downward, not in line with the first metatarsal head, and that's more typical of an acquired flat foot where the navicular is dropped, the calcaneus is flat, and the talar head's plantar flexed. This is essentially an acquired flat foot deformity, not a genetic flat foot deformity. So if we can look at a detail of the anatomy, we can see the posterior tib coming around the medial malleolus in this picture. Here's the talus, calcaneus, navicular, medial cuneiform, and it's showing like a major part of its attachment on the plantar surface of the navicular tuberosity and half of the medial cuneiform. Then we see the spring ligament depicted here, kind of running from the calcaneus to the navicular, and then we see the close-ups in this picture here. So here's like a medial view of the ankle joint complex. We can see the talus, and it overlaps a little bit with the navicular and the calcaneus. So here's your succinecum tali here, the talonavicular joints in here. And so we have the posterior tib muscle coming down here, attaching to the tuberosity, this point of the navicular bone, and then extending distally into the medial cuneiform. And now it's been reflected, the posterior tib's been reflected back. And as it's reflected back, we see coming from the succinecum tali up over here to the navicular, this would be the structure of the spring ligament. And so this is the head right here of the talus. We can see the anterior kind of fibers of the deltoid ligament kind of coming over and wrapping around and blending in with the spring ligament. So, so there's this significant interconnection between the spring ligament and some of the deltoid ligament. So this is an important study that was done a few years ago that identified which ligaments are involved in people with something called posterior tibial tendon insufficiency, or this is also called acquired flat foot deformity. So it's been long recognized that people with tendinopathy of the posterior tib tendon, where there's no problems with the FDL or the FHL, that these people have concomitant problems in ligaments of the foot. And what wasn't recognized prior to the study is which ligaments were involved. And so here's a list of ligaments that were tested in this MRI study, looking at age-matched controls in people with posterior tib tendon dysfunction. So the idea was this study could give us a look at what's the muscle interaction that's required to engage the locking mechanism and maintain the health of the foot, and what ligaments are also important in kind of maintaining that function. And so what we see here is the plantar calcaneonavicular and interosseous, which is a talonavicular ligament, the interosseous talocalcaneal ligament, which is a subtalar ligament, are the most frequently involved in almost all cases, 90% for the spring ligament, 75% for the interosseous talocalcaneal, for people with acquired flat foot deformity or posterior tib tendon insufficiency. So what it means is that, yes, the posterior tib tendon has to invert to engage the locking mechanism, but it also means that those ligaments protect, or that muscle protects the ligaments that help control that locking mechanism, in particular the plantar calcaneonavicular that acts at this mid-tarsal joint. So its functional significance applies to the oblique axis of the mid-tarsal joint, and then the interosseous talocalcaneal ligament, which crosses the subtalar joint. Now, less involved were the deltoid ligament in 32% of the cases, and that may be because as the disease progresses, it was only involved in problems that also were occurring not just at the mid-tarsal joint and the subtalar joint, but also the talar curl joint, which is much less common. And then if we skip down here, we notice that the plantar fascia and the long and short plantar ligaments are just less involved in general. So essentially what this means is that, in terms of the role of the plantar fascia in supporting the arch, that it's independent from really the posterior tibial tendon function, and that really the posterior tibial tendon strength, the mid-tarsal joint, and the subtalar joint are all kind of interdependent, basically. And so if you want to engage the locking mechanism of the foot that involves inversion of the rear foot to make the foot rigid for push-off, you really need an intact posterior tibial tendon, a muscle structure, and the spring and the interosseous talocalcaneal ligaments. Now, in terms of severe flat foot, when these ligaments are ruptured, you can see this is pes planus deformity. This is the same as saying flat foot. And this is a severe flexible flat foot, so it's the where the joints, the midfoot's unstable, but the joints aren't fixed yet in a contracture. We can see this is a CT scan of the rear foot in weight bearing. This is kind of the jig they used to load the foot. And so essentially the people had their feet out straight, they kind of applied some load and then took a CT scan while they were under load and then looked at the position of the foot. So you can see in this case there's severe valgus here, so the calcaneus would be angled here, and then the tibia is somewhere over here, and so you can tell that's a fairly severe valgus angle. Well, this is the fibula, this is the tibia, the medial malleolus. Here's a cross-section of the talus, and this is a cross-section of the calcaneus, and we can see that essentially the subtalar joint is subluxed. It's subluxed so much that the lateral side is abutting against the fibula in part, and this line here shows that part of the articular surface is exposed, so it's not articulating with the superior facet off of the talus. So this is really a subluxed subtalar joint. And another view of the similar problem, just with slightly better images, we can see here these 76 patients had flat foot and lateral symptoms, not medial. And we can see here there's a normal kind of outline of the ankle mortise with the fibula, the talus. There's the calcaneus and the subtalar joint. We see a normal amount of space here. And then on the image to the right, we can see the same bones, talus, calcaneus, fibula. We can see that the calcaneus is shifted over laterally, is now butting up against the fibula, potentially explaining those lateral symptoms. In addition to that, during loading, we also had impingement in the sinus tarsi. So here's the sinus tarsi here. This is the calcaneus and talus. And so there's the subtalar joint, and you can see some abutment of the subtalar joint with the talus against the calcaneus when the deformity is extreme. And so that isolates the function of the hindfoot, where the flat foot can become so extreme that we have lateral symptoms, not just medial, and that's only when the hindfoot eversion is quite large. Now, for more, if we now shift attention to the forefoot, we look at this video here, or x-ray here, we can outline the talus, and there's the navicular here, so that's the talonavicular joint there, and then this is the cuboid bone, or I'm sorry, the calcaneus bone and the cuboid bone in front of that, so this is the calcaneocuboid joint. So this is our metatarsal joint here, talonavicular and calcaneocuboid. So one of the things we look at is the medial alignment, looking for the head of the talus to kind of run down the shaft of the first metatarsal. So this is fairly good alignment here. If we compare that to the radiograph on right, which is abnormal, what we can see is that the talus is now adducted, so the talar head in blue is pointed off here medially, and then the forefoot has swung laterally. So essentially what that means is that the forefoot's abducted around the oblique axis of the mid-tarsal joint, which would be here. Here's your calcaneocuboid joint here, and then your talonavicular joint here. So that would be your mid-tarsal joint there. And we can see that this abduction of the forefoot would be expressed clinically as the too many toes sign when we looked at the person from the posterior. Then if we also look at how this deformity might cascade up to a more proximal joint like the talocrural joint, we can look at this radiograph where we can see that the eversion that's happening has caused this impingement on the lateral fibula, but now it's also causing some abnormal alignment at the ankle joint itself, where it's tilted too far laterally of the calcaneus relative to the tibia. So this hindfoot eversion causes MLA lowering, forefoot abduction, but also may have this effect on the ankle joint. Now, when it does have this effect, what we know is that the deltoid ligament is now compromised because it no longer holds the medial talus up against the ankle mortise. So in summary, adult-acquired flatfoot or posterior tibial tendon dysfunction is associated with very specific ligaments of the foot and ankle. In particular, the talonavicular joint, we have the plantar calcaneonavicular ligament or spring ligament. At the subtalar joint, we have the interosseous talocalcaneal ligament, and then less frequently, but when the talocrural joint is involved, we have the deltoid ligament. The joint positions that are associated with this are talonavicular joint, we have abduction and dorsiflexion. That's around the mid-tarsal joint oblique axis, and then the subtalar joint, we have hindfoot eversion. And then extreme cases of flat foot, the talocrural joint, there's a lateral tilt or eversion in the frontal plane that is connected with deltoid ligament damage. And then also we have note that the muscle mechanisms that engage muscle actions that engage the locking mechanisms are also potentially not functioning correctly. So if we try to look at how this plays out in a person with flat foot as they try to perform a heel rise, we can kind of watch this video. And so we're looking at the medial side of the foot, and you can notice her foot is quite flat to start with. And if we watch, we can see here at her attempt to do the heel rise, she's already unstable and plantar flexing her midfoot. Now she's going to be able to perform the heel rise because she's also helping with her arm. She's holding onto a bar that's helping raise her up. But we can see here she's not really getting much contribution from the forefoot in terms of plantar flexion. Now she's going to lower down, and essentially she wouldn't be able to perform the heel rise without using upper extremity support. Okay, so this is another view of her right foot. And here she's raised, she can raise up on both, but we're going to ask her to lower on one. You can see at this point that she has plantar flexion in the first metatarsal, so she has some angle. She's achieved, using a bilateral raise, she's achieved a kind of a arch position, but watch when she lowers that she loses control of that arch about halfway down. There. And then she lowers. And so that also arch lowering experience for her was painful. And so what we're learning is that the muscle control in the face of this kind of instability, she could achieve the arch raised position or neutral position that you would normally, but she can't control it because of the stability. So it's likely that the function of the spring ligament and interosseous talocalcaneal ligament make it difficult for her to engage the locking mechanism despite some remaining muscle control. So here's an example of a patient with extreme flat foot and with a fixed forefoot varus deformity with posterior tib tendon dysfunction. And the difference between this and the previous foot is the previous foot was flexible. In other words, the arch could be corrected. But if we look at this picture here, this person's been placed in, the hindfoot's been placed in subtalar neutral by palpating the sides of the talus relative to the ankle joint and aligning the rear foot. But if we look here now, we can see is that the foot's off the ground in a forefoot varus position or an inverted position around the longitudinal axis of the mid-tarsal joint. And this is a fixed deformity, otherwise the patient would be able to place their toe on the ground. If we kind of now watch this person during walking, we can see that if we kind of bring them back here where they're on the ground here first, we can see first there's a large amount of rear foot valgus or hindfoot eversion, and we can also see the too many toes sign here. And the person's going into dorsiflexion when they should be kind of pushing off here as they go to land on the opposite foot. And so essentially this is a really severe flatfoot problem. And there again, there's another step. And now let's watch it in real time as we go through. Okay, so we can watch it in real time again, and we can see for each step that the person's not really pushing off with that ipsilateral leg. They're really pulling their foot off instead of pushing off with their ankle plantar flexors. And that's because of the midfoot instability. And so as an example, if we ask the person to push off just from a standing position, so they're going to perform a heel raise, this is the kind of motion we see, right? So if we freeze it here, the person, in order to get their heel off the ground, what they've done is bent their knee and really dorsiflex the midfoot. And the ankle really is not going into any plantar flexion at all. So they're raising their heel by virtue of just of stretching the plantar flexor muscles as the knee bends into dorsiflexion. And we can kind of finish that. But that's their attempt at a push off. So this person has severe flat foot with hindfoot valgus and forefoot varus, and the consequence of that is ineffective push off during gait. So the gait compensation is a pull off, and we can see that when we note that they're unable to perform a heel rise task. So in summary, the midfoot instability is a significant reason why people with flat foot have a difficult time completing a heel rise task or push off activities, as for example during gait, and therefore have to switch to alternative functions. Now, what we do know and we're interested in is because of what we know about foot kinematics, we were interested in how peroneus longus or fibularis longus muscle can plantar flex the first ray in terms of training in these individuals. We're always attempting to restore the posterior tibialis muscle relative to raising the arch and adducting the forefoot and inverting the hindfoot. In terms of the FHL, FDL, we know they assist the PT muscle. However, they're less effective at raising the arch and have less physiologic cross-sectional areas. So we know that the main driver is the posterior tibialis muscle and then the fibularis longus muscles. And then we really don't understand the relative contribution of the intrinsic muscles of the foot, but we know that clinical examples of dancers and other athletes can have quite hypertrophied arch muscles, and we're interested in how these muscles can also facilitate arch raising or support of the medial longitudinal arch.